Patient outcomes matter. Our job as regenerative specialists is to give our patients the best chance to get the results they're looking for. That's why they're coming to us. They're paying out of pocket. This is a service not covered by insurance. It's on us to set them up for success. That's what I'm going to talk about today, specifically as it relates to PRP, because as Dr. DeWald mentioned, PRP is not all created equal. It's 2026. I've been doing PRP for 20 years, and a lot has changed over the past 20 years. Specifically with what we know about PRP, we know so much in the last 5 or 6 years. So many studies have been published. We now have meta-analysis where we can sort out why some studies show that PRP works and some studies show that PRP didn't. And really what it comes down to with what we know today is all about precision. So we're going to talk about a precise diagnosis that guides the right treatment recommendations for our patients. It's going to be involving precise patient education, both pre as well as post expectations for their procedure. We're going to need to talk about a precise precision. It's already been alluded to. Platelet count matters, dose matters. How we go about doing this makes a difference between a successful outcome and not having the chance of having a successful outcome. And it needs to be performed with precision. We need to use guidance and make sure, like real estate, location, 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 we deliver the product to the right area. And then we need to have precise pairing. There are multiple adjuncts that are going along with PRP now, and we use these synergistically to optimize our outcomes. Disclosure, I am an investor in Data Biologics, which is an outcomes tracking registry that I invest in because I believe in it and it's advancing our field. Learning objectives are in your course handout. Okay, so we're going to start with precise diagnosis. So obviously everybody's familiar, we do a history, do an exam. When we're doing the history, not only do we want to just get the basics of where does it hurt, how long has it been hurting, but we also want to know how is this interfering with your life? What can you not do today that you're wanting to do? Because that's what we need to be setting our plan up to try to get patients back to what they're trying to accomplish. And we want to take a combination of both their history and their exam, tie that in with the imaging findings to piece together where do we need to direct our treatment. We get MRIs on somebody over 50 with no symptoms, stuff's going to be abnormal on there. So again, we've got to tie in what's abnormal on the MRI, what are their symptoms, piece all that together to come up with our treatment plan. And then when we're looking at our imaging, again, precision, we're not just talking about, well, it's knee arthritis. Again, 15 years ago, you have knee arthritis, we're going to throw some PRP, well, actually, 5 years ago, 10 years ago, we weren't really doing PRP for arthritis as much. Certainly not 20 years ago. It was primary tendons is what I was using PRP for. College athletes or other people are trying to get back with a chronic tendon issue, but really that shifted, and now one of the primary indications that I'm using PRP for is arthritis. But the arthritis protocol that I'm utilizing for somebody who has a mild Kilgren-Lawrence 1 or 2 osteoarthritis is different than somebody who has Kilgren-Lawrence grade 4 osteoarthritis. And then we also have bone marrow edema. Is anybody familiar with bone marrow edema for arthritis and how that impacts things? Yeah, so if you have bone marrow edema, we're going to need to change our plan in order to have the highest likelihood of success. Because if you have bone marrow edema, this is no longer surface level, this has gone to a deeper level, and we need to adjust our management plan to account for that. Also, when we're nailing down our diagnosis, we can use some other tools to help us really fine-tune where things are coming from. So hips, for example, hip pain, they come in and it's like, well, it hurts here, and like I just said, somebody who's 53, they're coming in and they have hip pain that's here, and some of the exam looks like maybe it's arthritis, and some of the exam looks like it's glute tendons, and then the MRI, of course, anybody over 50 is going to have gluteal tendinopathy on their MRI, and they're going to have a degenerative labral tear and freak out, and what are we going to do to fix the labral tear? And it's like, hey, we're not fixing the labral tear, that's not how this works, but then, when they hurt here and the exams mix, and it's like, well, do we do an intra-articular intervention or do we use something into the gluteal tendons? Where's the pain coming from? Well, I'll use diagnostic injections for this all the time. So utilize an anesthetic only. I go with what I think the problem is, and we'll inject the anesthetic there and reassess 15 minutes later and see if it changed their symptoms or not. If it did, we know we're on the target. If not, then we go to the other area. Another tool that we can use in a very similar way is focused shockwave or extracorporeal shockwave therapy. Is anybody using shockwave in their clinic already? Okay, so for focused shockwave, that involves sending a beam of acoustic energy through tissue. When it hits unhealthy tissue, you will feel discomfort. So when we're doing this from a therapeutic standpoint, when we get that pain response, we know, okay, we're on the area of discomfort, and now we're going to dial up the dose, and we're going to direct this therapy to that area. However, we can also use that same component to help us from a diagnostic standpoint. So now, instead of poking somebody with a needle, if they don't want that, I can put focused shockwave on the area. Does this reproduce your pain? If so, okay, we found our answer. So again, nailing down our diagnosis can help us guide our treatment. And then also for, again, our precision diagnosis, don't forget about the mimickers. The tennis elbow that has been going on for forever, and they've seen everybody, and lo and behold, they have posterior interosseous nerve entrapment, not tennis elbow. Or same thing, I had a college athlete that was sent to me, and it's like, oh, they've got horrible plantar fasciitis, and they've had all of these things. They had shockwave therapy, it didn't help, and shockwave therapy is great for plantar fasciitis. Well, it's because they have Baxter's nerve entrapment, and so they were directing attention to plantar fascia tissue, and the issue is a nerve entrapment. So we really want to get fine-tuned on that. Okay, so precision patient optimization. So we need to have proper patient education. They need to have expectations. They need to know how to most optimally prepare for their procedure. And that requires you to be educated, because we need to be the ones providing that education for our patients. So we need to not just add this on as a side thing that we do as part of our overall orthopedic practice, but we really need to invest in our education on this so that we can educate our patients properly. We need to let them know what the procedure expectations are. What's the likelihood that this is going to help your condition? And we need to know the date on that so we can counsel them on that. What is this going to look like afterwards? How long is this going to make things feel better? Hopefully. And then we also need to look at, for our procedural optimization, do we need to look at holding medications or supplements, looking at metabolic optimization, breaking that down into more detail. As we're looking at likelihood of success, expectations for management of osteoarthritis versus a tendinopathy. For osteoarthritis, really we're hoping for giving a period of time where they're feeling better, kind of like what happens with steroid injections or a viscosupplement injection. You're going to feel better for a period of time. Obviously, a platelet injection is much different than a steroid for all the reasons of not promoting acceleration of the joint deterioration like a steroid does, but from the standpoint of providing pain relief for a period of time, it's similar, as opposed to a tendinopathy. Our hope is with a biologic, we're actually getting the tendon to repair, and hopefully they're not coming back to see us for this down the road because we've actually healed the condition. We also need to look at the likelihood of success. Different joints have a different response rate. And then similarly with tendons, some of our larger tendons like patella and Achilles have a much bigger load that goes through them, and sometimes we need more than just one adjunct or one mode of biologic for that intervention. We also need to have post-procedure response expectations. They need to know they're going to feel worse before they feel better. I've had people come in saying, I want to get this injection this week, I have to have it this week because I have a big tournament coming up this week and I have to be better for it. Well, it doesn't work that way. You're not going to do well at all on your tournament this weekend if we do a platelet injection today, because you're going to be feeling worse at that time, and you need to know you're going to not feel good for 2 to 3 days afterwards for sure, maybe up to a week or two, and it's going to be 6 to 12 weeks before we're really seeing optimal results. And so having that expectation conversation with patients is important. Yeah, and then for pre-procedure instructions, the general rule of thumb, and there's debate, and it's kind of a hard thing to study, but in general we try to have patients hold NSAIDs for a week before. If they're on an anticoagulant, depending on the anticoagulant, that turns into a little bit of a mess of trying to navigate all of the things. At the very end, there's going to be a code that you can scan that's going to give you links where I've tried to find where the open access articles are. I have their website, so at the very end there's a link, and then it'll take you to my website where I have all of those there. So there's a page that I have specifically for the anticoagulants that talks about half-life and when to stop, when to resume, all of that. So that's a resource that's there for you. Supplements like turmeric, fish oil. Also for optimizing everything we can do to increase their baseline platelet count means we have more platelets that we're starting with in the processing, which makes it easier for us to have more platelets at the end. So doing a brief period of high intensity exercise prior to the blood draw has been shown to bump the platelet count up. Post-procedure, to ice, to not ice. Some people say ice if you need to afterwards, some say don't ice. I tell people, there's not a study on it because ice is an anti-inflammatory. We've just created an inflammatory response. If we could not ice, that would be awesome, but if you're needing it for pain control, then it's not gonna undo what we've done. For NSAIDs, I ask them to hold NSAIDs for at least 2 weeks after the procedure, but preferably 6 weeks. They're not gonna be feeling like doing much for the first 2 to 3 days for sure, and I definitely wanna have them stay limited in their activity for the first week or two after the platelet injection, and then they can gradually increase. And then when we're talking about a tendon issue, rehab, load management, we'll talk about more detail here in a little bit, is a key component of this. Article that was published this year on metabolic optimization before orthobiologic therapies. Again, I've got a link to this full article. The bullet points, we want to have optimal glycemic control. If if their hemoglobin A1C is 10, probably they're not going to have a great response to what we're doing. Elimination of alcohol, tobacco. We want to make sure we have good strength, sleep hygiene, gut health. Those are the bullet points, but again, the full article is linked in here for you. Okay. Procedure itself, precise procedure. We're going to talk about PRP dose, as has already been alluded to, leukocyte rich versus leukocyte poor. And then where are we going to inject? Again, for like a knee, are we just injecting in the joint? Are we going to inject the MCL, the meniscus? Are we going to do an intraosseous injection? Ultrasound guidance, do we activate, do we not activate? I'll just close that conversation. A lot of the early studies, we're talking about activating the PRP. From a practical standpoint, most of the time people are not activating with calcium chloride with the injection. We just inject, and then when it's exposed to the unhealthy environment, the platelets are activated without us injecting anything further. And then also, do we do one injection? Do we do several injections? Again, early on, the studies were showing most of them were doing a series of 3 injections. We'll kind of break down some pros and cons of single versus multiple. Spoiler alert, almost always I only do one. So as I mentioned before, why is there a difference in PRP outcomes when we looked at the studies? So again, when I started this 20 years ago, we all referenced the one Mishra study for Tennisel. Was like, hey, it looks like it worked pretty good, and so maybe it'll work for this as well. We're not really sure. From like 2010 to 2020, this study shows PRP is a miracle drug. This one shows PRP is garbage, and then you're looking at going, well, what is it? Why is there this high variability? Well, there were studies where they were putting in different degrees of diagnosis in the same category. So if it's just knee arthritis, well, how severe was the arthritis? We don't know based on what was provided in some of those studies. What was the platelet count? Again, a lot of what we found is low platelet count was associated with those studies that showed that PRP was not beneficial. And then a lot of the studies didn't utilize ultrasound guidance. It was landmark guidance, and so that makes the difference in outcomes. I just had an athlete that I did a elbow UCL injection on this past week. He had a low platelet volume PRP that was landmark guided, last fall, and it didn't feel very good when he received it, and he didn't have a good outcome. He may not respond to the one that we did. Not everybody responds to everything that we do, but a landmark guided low dose PRP injection did not get him set up for success in the same way that studies show that a high dose that's ultrasound guided does. So dose matters. What dose should we be looking at? In general, if we're talking about ligaments and tendons, I shoot for a 6 billion dose platelet. If we're looking at a large joint for arthritis, the Bansal study showed that a single injection of greater than 10 billion platelets was associated with a good response rate that had symptom relief sustained for a year was his outcome mark. At about the same time as Bansal's study, Chu's study came out. His study was a series of 3 platelet injections weekly. His dose was closer to 5 billion. Now, the argument that you can give for doing a series of 3 injections based on these studies, the Chu study, when he looked at articular cartilage volume at the follow-up, there was articular cartilage volume preservation compared to the control group in Chu's study where you did the 3 injections. Bansal's study did show the symptom improvement for a year, but when they measured the articular cartilage, it did not demonstrate the same preservation effect that was statistically significant We definitely need more studies on this, but yeah, not sure if that single injection, even though we're getting at a high dose, if we're getting that cartilage preservation to the same degree that a series of several smaller doses does. As has already been mentioned, older patients need a higher dose for response. One little asterisk, if you have a younger patient that's seeing you, like in your 30s for arthritis, so you know, a big part of people that are coming to see me for this are people that have post-traumatic arthritis. So 35 and you have a 68-year-old knee. It's a bummer, and we don't want to put steroids in there and accelerate this process. So they're looking for an alternative. So we're doing platelet injections. It's like, hey, we need to do a big dose. So I had a patient. We did this. He had the normal 2 to 3 day, hurt really bad, but then he started feeling better. And then about 3 to 4 weeks later, call back, hey, my knee's painful, it's swollen, it's all these things. I'm like, oh no, this can't be good. Oh, it's not red, that's good. Comes in the office, drain the fluid, normal yellow, synovial fluid appearance. I have a cell counter that I use to measure all of our platelet dose. So I was able to throw it in and do a cell analysis on it. Nothing looked infected. For him, because of the inflammatory response, I did put a little bit of steroid in there, which I cringed when I did it because I hate to put steroid in these situations, but it did help get things calmed down. Interestingly, there was a presentation at Toby this past year where somebody had a case, they had 3 similar cases, and the common thread was all of the patients were younger, like in their 30s. So that's the asterisk. In general, big dose is good, but patients that are younger, maybe we don't want to go really big on the doses. And a lot of times when I'm doing my injections, we're getting like 15, 20 plus billion, and so a 10 billion might be okay, for a 30-year-old, but going those really high numbers, you can get that flare response. All right, so leukocyte rich versus leukocyte poor. I personally am in the camp of leukocyte optimized. So I want monocytes. I don't want granulocytes. And the nice thing is their gravity is such that when you're using one of the common systems, or any of the common systems that allow you to break that down, you can preferentially get high monocytes, so your white count is going to be high, your monocytes will be high, but you can limit the number of granulocytes so you don't get that big inflammatory response. And I know that says on there low leukocytes, and that's a typo. That should say granulocytes. In my mind, I put granulocytes as what I consider leukocytes and say we don't want those. So by not having the granulocytes, you have less post-procedure pain, but then you get the advantage of having the monocytes, which can then still differentiate between M1 or M2 depending on the environment. Okay, so delivery, precision. So this is glenohumeral injection. Is anybody using an ultrasound? Who's using ultrasound as their guidance? Okay, pretty much everybody. So yeah, so glenohumeral injection, you can see labrum here, needle tip going in, so we want to make sure we're in the joint when we're doing these. This is out of plane meniscus, so femoral condyle, tibia, meniscus here, and out of plane, so you're just seeing the little needle tip that's coming in. I kind of wiggle it to make sure we can see it more clearly on the picture. And then here is a UCL injection. I just put a couple clips together. So when I'm doing a UCL, so somebody who has all of the classic signs of a UCL injury but a normal MRI, we know that the tissue's not normal because we've just learned that over time. So in that situation, I'll actually go through and pepper all the way down the entire length of the UCL. The other thing about the precision delivery, we want to make sure that we're infiltrating the fluid throughout the tissue. We don't want to just put a needle tip into the soft tissue and inject and get that big black halo of fluid sitting right in the middle of all of it. In the same way that if you have an abscess that's walled off and you have that ball of fluid there, we can't, like, antibiotics can't get in there to fight the infection. We want that, we don't want all that platelet in a ball sitting there. We want to infuse it through the entire tissue. Also, if you just inject a ball of fluid into that area, it's also more painful, and so that's not awesome either. All right, so conditions that we can treat with PRP, there's great evidence for like tennis elbow and forever, the arthritises, some things that don't respond as well as I alluded to before, the larger tendons, sometimes we have to do more than just platelet. In general, with osteoarthritis, our response rate with knee arthritis is better than the response with glenohumeral, which is better than hip. For follow-up, I'll have people check in at 6 weeks. We'll reevaluate their symptom response. I tell them I expect you to see 80% of the improvement you're going to receive at the 6-week mark. And if you're feeling largely better, then I expect the rest of that pain relief to come over the next 6 weeks. If they feel like, well, I got like 30 to 40% better, that's generally when I say, well, maybe we'll consider adding in another injection, but that's like less than 5 to 10% of the patients that I see will I do a repeat injection on because of a lack of response. If you're doing hip arthritis injection, they're gonna hurt. That's a smaller capsule, so a lot of times they'll end up using crutches or a walker for a couple days, so I prep them ahead of time, like, hey, you might, if you don't have a walker or crutches, you might wanna have something on hand, because it's really, really stiff and it hurts the first 2 to 3 days. Yeah, you can, and then the gray line is all clinics across the country, their outcomes, and this specific graph is desired functionality. It's a scale of 0 to 100, asking people like, okay, how much of your activity that you want to do you feel like you're able to do? And the big thing that you'll see is at 1 month, we're starting about the same. My patient population looks like has just a very subtle, I don't know that that's even statistically significant, but looks like they start with slightly lower function, and at 1 month, there's a very big spike, and I really think that's related to the incorporation of the energy devices along with the biologic injections that we're doing. And also, as I mentioned, we use very high dose, and then we fine tune our program to match like what the diagnosis is. So I promised there'd be a QR code so you can scan that and access the articles. There's a couple that you can only get the abstract on, but every one that I could find that had the full open access article, I put the link to the full access article. So in summary, precise diagnosis matters. The dose of the platelet injection that we're doing matters. How we deliver that matters. Tracking outcomes and data and patient outcomes matter. And in summary, precision regenerative medicine improves reproducibility and outcomes with our interventions.